Oliver, Rachel Marsh, who's deputising, and we have apologies from Nia Roberts, Juliet Brown. Yolo Dahl was down on my list, but I can see him on the screen, so he is present, and also Ross as the Director of Ambulance and 111. Any other apologies for absence? I'm conscious that Abby needs to leave at 12 o'clock. Thank you very much. Well, the meeting is scheduled until 2. Having looked at the agenda, I think we can probably manage our business within by 1 o'clock if we can. Don't hold me for that. I'll do my very best. Are there any declarations of interest that anyone needs to make? No. And again, if there are, as we go through the agenda, please make those declarations at that point in time. We've got the minutes of the meeting held on the 26th of May. They've been circulated. Any issues in terms of accuracy, first of all? No, we're happy then to approve them as a correct record of our proceedings. Thank you, then they are approved. Moving on then to the action log. Aaron, over to you.
Thank you, Chair. 3 actions that are all proposed for closure. The first relates to the development of a risk assurance framework. That's proposed to be closed on the assumption that we approve the Joint Committee Assurance Framework at the end of the meeting. If that isn't approved, after you get to that item, we'll reopen next week. It's proposed to be closed on that basis. Second, in relation to rural response options and a request that we'll continue to update the committee on progress with that. There's an update in the Chief Commissioner report today with that commitment overall to provide recommendations in November. So that's on the forward plan to propose to close that action for that reason. And the final action we're proposing to close relates to more detailed updates or more granular updates in relation to our 2 financial position. That took place at our July Plan and Performance of Finance Committee. So we'll have to have that closed as well.
Thank you very much. Are people content for those 3 items to be closed? Thank you. Any other actions that have been missed from the last set of minutes? No, thank you very much. Then let's move on then to the report. So over to my report, first of all. Happy to take this as read. 2 issues I just want to highlight. One is the appraisal process for all lay members is now being concluded or just about to conclude, but all of the appraisals have taken place. And just to note, Juliet has now started as Chief Commissioner. She had a pre-arranged holiday for these 2 weeks, so is able to be with us today. I think he's settling well into the organisation despite a detached retina. And I just want to also just to congratulate her, Mel and Yolo for giving evidence to the Welsh Affairs Select Committee a few weeks ago. And I was watched the evidence session with great interest, and I thought that everybody responded entirely professionally and diligently to the questions posed by members of Parliament. Obviously, we'll look to see with interest the conclusions of that piece of work around cross-border activity and any issues or learnings for the JCC as part of that process. Any questions for me on my report? No, thank you very much. Then let's move on to the Chief Commissioner's report. Stacey.
Yes, I'll pick up the report today by Juliet. I'll take the report as read just to acknowledge the Welsh Affairs Committee as in the report as outlined. The financial position is later on in the report, and just to acknowledge that we have looked at in a little bit more detail some of the plan care targets around areas in specialist services, and there is a couple of services that are coming up or looking at the 104-week target, and they are notified in the report, and we are working with colleagues in Welsh Government and health board providers in relation to the plan care funding as and when should that become available. The report also picks up the individual Commissioner Directors report, so just hand over to the Commissioner Directors if there's anything to pick up by exception.
So I think just to take it as read, but to note that, you know, we've got ongoing kind of sustainability issues. So we haven't got anything new going into escalation level 3, but, you know, we're seeing impacts in terms of performance and things like that. So cardiac surgery in Cardiff has moved to level 2 in this period. And I think that's reflective of some of the broader system pressures around workforce and sustainability. But obviously we're managing those as part of business as usual.
Thank you. Sue?
Nothing specific. I think probably the only thing I would just draw your attention to is that we are closer to moving all of the patients from St Andrew's Healthcare. So there are 5 remaining patients, 2 of which have placements arranged, and there are 3 patients where there are ongoing inquiries to sustain the appropriate placements moving forward. And also just to update on the gender review, but that review is in train, and we're in the process of commissioning independent external expertise to support that review, and that's imminent in terms of those being appointed. So it's in a positive way forward.
Timescales for the review to be completed. So
Timescales for the independent review is by December time. So we'll have an interim report in December, and then final recommendations and implementation from the end of the financial year.
and the providers be fully engaged in that process.
Definitely, yes.
Claire, anything from ambulances 111?
Thanks, Chair. Just to draw people's attention, obviously, to the rural ambulance response section within the report. And this commits to the committee our intention to come back in November with some options in terms of delivery, but to re-engage the population through the next few months in terms of what is important to them. Conversations have been had with Health Board colleagues in terms of enabling that engagement period, and we'll be working to bring people together on the specifics over coming days, subject to your approval to take it forward.
Thank you very much. So there, let's take any comments or contributions in relation to the Chief Commissioner's report. The BDI, you will notice I've skipped over a whole part of the agenda, which we'll go back to in a moment. Let's start with Angela, then Rachel, then.
Thank you, Chair. You threw me a little bit by jumping to the agenda. So I have 2 comments. One is around St Andrews and one is around the rural transport, if that's okay. So first of all, around St Andrews, recognising there's still 5 patients there, 3 patients, 2 patients are moving. What assurances can you give about those 3 patients that are going to be staying there at the moment, that they are receiving safe quality care, considering the current situation in St Andrews?
Yeah, I can give you assurance that there's robust arrangements in place with case managements within the JCC, also with health boards, to ensure the ongoing safe care of those patients. That encompasses regular visits to St Andrews, regular engagement with the patients, and in terms of the ongoing arrangements for placements, they're being taken into account in respect of the kind of complex presentation for each of those patients. So yes, I can give you assurance of that.
Lovely, thank you so much.
So is there, just on that point, is there any further information that you've got in relation to NHS England's decision, or in principle decision, to provide to seek another provider for that service from an NHS organisation?
Yes, so I think that will also give further assurance that NHS England have put in place alternative arrangements with another provider in England to take over the running of St Andrews in the interim and into the immediate future. So that also gives assurance for the safe care of patients who remain at the site, and there are plans, not for the Welsh patients specifically, but there are plans to retain some patients within St Andrews on an ongoing arrangement under the care provided through those arrangements.
Thank you. Andrew, your second point.
Yes, and this is in relation to the rural transport proposal within the paper. So the paper refers to engagement taking place with health boards for their existing engagement activity. I have some concerns around that in relation to that engagement could get lost. I know that health boards have a significant amount of engagement activity taking place through the summer and the autumn months, and bringing it in to the fold of that could mean that people don't have a voice because they won't know that they're able to talk about that particular topic. So I would ask committee to consider that. We really need to make sure this engagement is meaningful. I'd also like to say that the engagement when it takes place, it needs to be meaningful in order to come back in November so a decision can be made. So that means that face-to-face and online engagement events will be required. I've had conversations with Claire around a midpoint review. I think that would be really helpful to have that midpoint review to look at the feedback that is coming in to date to see if any adjustments are needed, or actually if you are getting enough feedback, because you might need to adjust plans. I think that's good practice as well. Some comments around the information pack. I think it's important that information pack tells a story to date. This has been a journey, so I think the public need to really understand that. And it's important that people can, who are not digitally advantaged, are able to access that a physical pack as well, rather than looking online, which can often happen. I also think it would be helpful to have case studies within that information pack, because I know in the past it's been difficult for people to understand the concept. There's been concerns about the air ambulance bases and things. So I think having case studies within that will help people to really understand what's happening and what you're trying, what we're proposing now, which is about the world changing and asking people that basic question is what does good look like to you. I'd be really grateful if I could see the copy of the full pack so I can offer comment before that's released. And then just my final comment is in relation to SLICE. So the paper talks about our commitment to support the engagement. Just want to clarify what we'll be doing is promoting the engagement activity through the health boards, recognising that will look different in each health board, and we'll be in attendance at each of those events. And obviously I'll be providing our feedback as well in writing and at the November meeting, Chair. Thank you.
Thanks. I think that's really helpful. I guess it's important that we try and focus. This is not about reopening the issue around where ambulances are based. It's a very specific focus, and that was very clearly laid out within the judicial review judgment. This is a distinct and separate bit of engagement that we just need to make sure that we're undertaking. Claire, I'll bring you back in a moment, but maybe Rachel wants to contribute to this point as well.
Thanks, Chair. Yeah, I was going to just make a comment about this. A couple of points. One was that you will have seen in the minutes. I think there was a part of the action had been around the Welsh Ambulance providing some detail on performance across rural areas, looking at some of the the kind of reasons for difference. So just wants to assure the committee that was done, and actually it painted a kind of a bit more of a varied picture across both rural and urban areas. So that was, I think, interesting to see. And one of the comments we made is that in going back out to engage, it's maybe helpful for the committee to understand kind of what issue and problem they're seeking to find out about. But I think in terms of the engagement process that you've outlined and that Angela, you've talked about, we too kind of will support that where we can. Happy to, and we're hoping to attend those engagement events where we can across health board areas to listen in the same way as you will be interested in hearing the public's views. So yeah, that was really to say that we support the JCC leading on this. Thanks.
Thank you, Rachel. Claire?
Yeah, thanks both, really helpful, and we've had discussions outside of the meeting also, which has also been really welcomed. I'd suggest we continue those conversations following today's meeting to ensure that we do reflect, Angela, all the points you've made, and I'll pick those up as we design with health boards now over coming days how this looks, and truly grateful to Rachel and colleagues for this support, a true collaborative venture, I think. Thank you.
Anything else on that point, Nick?
Yeah, obviously a topic which is of great interest to our population. We really welcome this approach, and obviously there's the engagement side, but obviously we want to be equally involved in the and updated on the design of the service or mitigating actions that come out following the engagement. Noting that our board is always concerned because in terms of the ambulance performance times that we report to board, on aggregate, the Powys population always has the worst response for purple calls. So anything that can be done to improve that would be really welcomed. But we recognise the process that's ongoing. And then I do have a question on medium secure mental health, Chair, if that's okay.
Can you just hold that for a moment? I'll bring you back. Rachel, did you have your hand raised in relation to?
No, I
that
was going to
point?
make a comment on a different matter. Sorry, Chair. Thanks.
Right. Thank you. So thank you for the comments in relation to the rural ambulance response. Obviously, it appears that there's some further conversations that are needed and are also taking place around the terms of and the approach to engagement. I think that the committee would encourage those conversations to continue. Great, thank you. Rob, you've been very patient.
Yeah, a few questions for me. In terms of the rural ambulance response, the question I was going to ask is, do we have a definition of rural? So we're not necessarily looking for an answer straight away now, but the definition of rural, I think, might help. Can I ask other questions on the report, or do you want to go back to this?
Let me just bring Stacey on that point.
No, Rob, I was just going to say Ross isn't with us today. When he's back off annual leave, is there somebody I can get him to link in with?
Yeah, Steve Bonza, please.
Brilliant, thank you, Rob.
But Rob, your other points?
Just in terms of some of the elements of the paper, just wondering with the JC review and the challenges in Cardiff, if we've got any implications of that clarified yet. Again, that might be work in progress, so I appreciate that. And then in terms of some of the issues linked to the NEPS review, just a request if we can have some clarity around the structure now for the different groups. I understand there's been quite a lot of cancellations of meetings, which is raising some concern internally around engagement. So if that can be looked at, and if somebody can send me a clarification of that structure, that'd be really helpful, please.
Ben?
Thanks, Chair. Thanks, Rob. Yeah, absolutely. I can send you some work that we've been doing, which is seeking to clarify our commissioning assurance arrangements and strengthen them. So I'm having some conversations with Steve in your organisation around that, and I'll happily send them on to you so you can see.
And Stacey, the point that Rob raised in relation to the dispute with Cardiff and Vale, I think it's been resolved, isn't it?
Yeah, so we're just finalising the final details of the contracted arrangements between us, and yeah, in a positive space, Rob, I'm hoping to get everything dotted and crossed within the next week or so.
Thank you, Rachel.
Thanks, Chair. Yeah, the other point I was just going to make was around the NEPS, as we've just raised. So we note that your report says that we've got an improvement programme. That's obviously within the context of a kind of no investment year. So really it's looking at efficiency and productivity measures where we can, including things like ensuring we've got the eligibility criteria being applied correctly. And I just wanted to note for the committee and with Angela here as well that there's been quite a lot of engagement or communication, I suppose, with the public now to make sure that they understand some of those changes that we're making. But we really certainly welcome that joint approach. We found the joint groups on NEPS to be really helpful over the last few years. And so the confirmation and the clarification of how that will continue, I think would be really good to see. Thanks.
Thank you. Paul, what was yours in relation to?
It's in relation to ambulances.
Okay, yes,
yeah.
Go ahead.
Yeah, just on the clinical support hubs and the remote clinical assessment. I know there's ongoing work on that, but I think it kind of raises broader issues because we've talked before about clarity on pathways and potential duplication. And I think that's quite an important piece of work in terms of setting out principles in on how we handle that in service transformation, those clarity on pathways and assuring that we're not sort of overlapping.
Claire, can you help with that? Claire, you're muted.
Apologies, Paul, thanks absolutely for that point. I know we've had a brief discussion on it more generally. Yeah, really important piece of work, and I know something that's coming back here in October. There are lots of stakeholders So to make sure that we are not duplicating, it's really important that we are bringing them together on a regular basis. So your point absolutely noted, and something that across our organisations we've been talking about seeking to minimise. So thanks, Paul.
And Nick, in terms of mental health.
Yeah, so obviously we understand the benefits of having the seclusion suites in Caswell in terms of both patient benefit and financial plan. So the question is, what is the contingency plan if that capital case isn't supported?
Sue?
I think that's a really good question. I think at the moment we're hopeful. We're near to a decision being confirmed in terms of that capital investment case. I think that part of the remit of the strategic review is to look at sustainable commissioning arrangements for the secure pathway going forward, taking into account medium and low secure. I think we would be hopeful that there would be investment in additional seclusion and facilities within Caswell, because I think that's a key barrier to occupancy currently, and I think that's something that we would need to discuss with Swansea Bay and providers should we be in a position that that's not approved by government. But the decision is imminent, from what I understand.
Yeah, thank you. And I appreciate this is a commissioning conversation predominantly. For me, picking up what you were just saying, so about the strategic review is really important. This is a two-warded service, and actually our conversations with the national commissioning, the provider collaboratives across the board have been really helpful for us as a provider organisation, and we need to make sure the review is taken forward in that context about how we can make sure we've got the right capacity for Welsh patients and the right makeup in terms of sort of the categories of patients, and making sure that therapeutically we're meeting their needs in every case effectively, and that's what the review needs to pick up. But I think this is a risk because we know capital is, and if you think about the escalation report, it's not just the seclusion rooms, it's the estate is now quite tired in terms of providing the right kind of therapeutic environment for individuals.
Was yours in that relation to that point, or?
No, it was that Rob asked a question about JC.
Sure.
So in terms of the JC certification, Cardiff submitted their full response to JC earlier in the month. We're expecting a response from them within the next 1 to 2 months. The capital case has been received by Welsh Government, and Juliet received a request to support the capital case in terms of the case for change and why it's required. That went in last week, and we also submitted details for the evidence around how we would consider additional revenue consequences of that, obviously bearing in mind that the capital environment is the key element. And as per the paper that came to CCLG, as contingency, we're looking at what the alternatives might be should that certification not be continue to be granted, which would be around outsourcing, which would need to be the case for CAR-T, which is the smaller numbers, and arguably more achievable in terms of commissioning. However, not positive in terms of patient experience because of the intensity of the treatment. And obviously then the options as we go forward around BMT, around how do we use the two-site model slightly differently, and what are the opportunities around derogations, etc. Because the outsourcing opportunities for BMT wouldn't be sufficient to cover the demand that we've got. So there would be a patient impact, and around things like travelling times and outcomes, etc.
Thank you, Suzanne. You've been very patient.
That's absolutely fine. Really good to see in the report the progress on reporting of children and young persons data from the gender service that's provided. So look forward to seeing those dashboards. Digital therapies, I just wanted to check what the age offer was in the specification. Is it all age, adult only?
I will need to double check. I mean, I believe it's adult only and it's over 18, but I'll check that and come back to you to confirm.
I suppose it sort of sits with my other point really around eating disorders management for children and young people. Because again, I just don't actually assume we don't have any provision because these are often very difficult cases to manage. So I don't know the answer. So it'd be maybe useful at some point for some information to be brought to the committee around how that is provided. Whether, I mean, I know they're two different things, but it sort of points the piece around children and young people generally, I think.
So perhaps then let's have an update report around that sort of broader children, young people, mental health at our next JCC
Because I
meeting.
think they're driving this cost, actually, the requirements complex, isn't it? And expert,
Yeah.
obviously.
See whether you can pick that up in your next section of the Chief Commissioner's report, but let's take it as a clear action from today.
And I know we'll come on to it in the more detailed performance report, but I think the WAST community response monitoring, so there's a triangulation measure that we need to be monitoring, which is both ambulance handover response, but also community response in the location of the provider that's working with WAST to achieve the ambulance handover and in the border regions.
Okay, thank you. Any other issues or questions on the Chief Commissioner's report? No, the report? Sorry, Rob.
Yeah, thanks. Just one question in terms of the nighttime cover issues of the major trauma desk. I see that there's a workshop going to be established. Will there be an opportunity for an AB rep to attend that workshop, please?
Claire?
Yeah, thanks, Rob. The invite list has been managed by the network themselves, so I'll check to see that health boards have been invited for you, but I can't see any reason why not at all. So let me do that and come back to you.
Thank you very much.
Thank you. Let me note the Chief Commissioner's report. Thank you. And again, my apologies, but scoop now back to the reports from the committees. And first of all, let's go to the Quality, Safety and Outcomes Committee. Anything you wish to flag, Susan? I know we've got a short video shortly, but anything in particular you want to highlight from the committee's?
Just, thank you, Chair. Just in terms of taking the paper as read, just in terms of the 5 items in terms of the red box, the top escalation. I suppose in terms of the fragile specialist services and the workforce pressures which continue, and those will be are going to be considered through the emerging joint committee assurance framework. But we wanted as a committee to say that in terms of the JC accreditation risk, there has been reference to JC, and these continue to be highlighted, and assurance continues to be sought. In relation to Caswell, we've already rehearsed some of the issues today. A return lay member visit has been requested. And then in relation to cardiac surgery, which has now been moved to a level 2 escalated intervention. But it still will be something that will be highlighted in terms of the committee. And finally, the Wales individual patient funding request panel, just with better attendance from health boards, which is very good because that drives panel resilience. We're looking forward to greater Powys health board attendance.
I'm sure Nick's heard that. Right.
Thank you, Chair.
Thank you. Any specific questions on the escalation report? I believe there is a video that we're going to now see, which I think is a useful framing for some of our thinking.
Importantly, Chair, it is our first Welsh language patient story in the 2 years of the JC, and want to thank very warmly colleagues from Swansea Bay Health Board who supported.
Thank you.
So fi ar dialysis nawr ers tair blynedd. O'n i'n gwybod am blynedd bod problemau gyda'r kidneys, hynny yw o'n i'n cael cerrig yn y kidneys a pethau. A wedyn wrth nhw ddarganfod, pan o'n i'n mynd i'r tŷ bach, o'n i ddim yn gwacau'r bladder yn llawn. Ges i ddoi llawdriniaeth i glau'r kidneys allan, yr rennau allan, ac oedd dy fi rhywbeth o'r nhw staghorn calcium yn ynddo fe. Nath hwnna wedyn cadw'r kidney popeth i weithio am cyfnod, ond o'n i'n sylwi bod fi'n mynd i dwmlo yn really ddioel, o'n i'n dwmlo'n sic, o'n i'n dod â bwyd nôl trwy'r amser, golles i 9 stôn bron bod. O'n i'n cael gwaith cerdded, byddwn i'n cyrraedd y gwaith, byddwn i'n eistedd yn stafell ar y soffa, byddwn i'n mynd gydre yn y nos, literally just tynnu blanced dros y fi'n y gadael, fi'n hyd yn oed newid dillad. Ond felly, fel a bu oedd o'n i just yn ymladd y peth trwy'r amser, a just gweud bod fi'n twmlo'n iawn pan o'n i ddim. Gofres i fi mewn wedyn i'r emergency dialysis unit, am rai ddweud, o'n i'n terrified o'r newidiadau ddim wedi bod yn bywyd fi, achos fi'n joio dod i'r gwaith, fi'n person cymdeithasol iawn. Dath Dr Eithar, sef y consultant sydd wedi bod yn hollol wych. Ffono fi Boxing Day, ffono fi yn y gwyliau pan bod e'n India, mae fe'n cysylltu, checo bod fi'n iawn. Gallai ni beth gofyn am well consultant. A nath ei weid, reit, yr opsiwn sydd yn ni, pam wneud i fel self-care. Mae rai pobl yn cael ei, ni gyn i'n cynnig ei lot o bobl, ond i bobl sydd yn ifanc fel ti, mae fe'n golygu byddech chi'n cael fwy o ryddid. Nath esbonio bod system o'r enw self-care, sef adran bach yn Treforys, lle chi'n mynd mewn a chi'n cael hyfforddi i wneud y dialysis adre. Dechreuais i gyda yr adran self-care, a wedodd Dr Eithal, o bydd Emma y prif nyrs, bydd hi'n cysylltu â chi. A o fewn rhyw dridiau, ces i galfod ffôn wrth rwy'n a, Emma sy'n enll i ti, check. A ni'n meddwl, a ddi siarad Cymraeg? A'n syth o'n i, a fi'n gweud, fi'n nabod so-and-so, fi'n nabod hwn, pawb o'n i'n nabod, oedd nhw'n nabod Emma. A ni wedi clywed lot am Emma yn yr ysbyty, wrth cleifion eraill, o'n i wedi clywed lot pa mor dda yw hi. Oedd ei fel cael ffrind yn yr ysbyty mewn ffordd. Mae gen i'ch cornel chi trwy'r amser. Benderfynnes i bod fi'n mynd i fynd i gydrial wneud e. A pan gyrraeddes i sylwi bod lot o bobl yn dysgu neu'n siarad Cymraeg yn yr adran. A adran bach yw i ryw 8 claf sy'n ar y tro, a ryw 4 nyrs, a diwrnod cynta, oedd 2 o'r nyrsys yn siarad Cymraeg. Oedd yn ffantastig i fi, o'n i'n twmlo'n gartrefol yn syth. Mynd nhw'n eich chi dwmlo fel eich ffrindiau chi, fel pobl proffesiynol i nhw. Mae pethau chi'n siarad a mae pethau chi'n trafod yn gyffredin i chi gyd, a maen nhw'n deall y problemau chi'n mynd trwyddo. A mae jyst cael pobl sydd bach mwy upbeat. Mae'n ei byd o'n i. A hefyd, na gydymon y nyrsys, mae un o'r bobl sydd yn yr adran self-care, Elin, mae wedi bod yn rhyw 20 mlynedd mewn Cymraes eto, Gwm Gwendraeth, mewn uniform gwyrdd, ond i fi'n bydden ni'n mynd at hi gynta o ran pawb. Mae gymaint o brofiadau. Cred i weithiau, bod pobl yn edrych ar beth o rwy'n ar bapur a nofio bod y profiad o rwy'n o fel i ddelio gyda rwy'n, a rwy'n sydd wedi gweld rhywbeth o'r blaen. Ac yn aml iawn ti'n mynd mewn. Y diwrnod ges i mewn, ffones i yn y bore, dweud, cynda, fi'n credu bod y ffliw arno i. O, mae'n rhaid ti ddod mewn, ffones i y bore di merch yma, o'n i ddim yn gwybod ble o'n i. A wedes i, Emma, llai beth gyrru mewn eddi. Wedi, mae'n rhaid ti ddod mewn, lai ambulance i ôl ti, lle di gael trafnidiaeth. So, mewn na fi, a wedyn y diwrnod nhw'n meddwl tawch mo anwyd gwael oedd e. Wel, y ffaith bod fi wedi mynd fanna i gael dialysis, ges i prawf gwad yn syth, ond nhw'n ffono fi bore di a i've got viral pneumonia. Wel, byddwn ni ddim wedi gwybod na, byddwn ni. A byddwn ni wedi trial cadw i fynd. Un peth sydd wedi bod yn gret o fod yn rhan o'r adran yw bod chi'n twmlo môr ddiogel. Chi'n gallu mynd mewn ar unrhyw adeg lle mae unrhyw broblem yn codi ydych chi. Mae'n golygu bod y gofal yna 24/7. Ar funed maen nhw'n siarad Cymraeg a chi jyst yn twmlo gymaint mwy cyfforddus. Chi yn jyst yn ymlacio. Chi'n twmlo bod chi'n ddiogel mewn amryw ffordd. A sawl person Cymraeg ar y ward yn llan o'n una. Mae'n ffantastig cael Dr Jenkins yn ffeil siarad Cymraeg, so goffa fe meddwl am yn Saesneg. So mae lot o ni siarad Cymraeg trwy'r dydd, bob dydd. Weithiau sy'n fi'n gwneud adre, fi'n gwylio mynd mewn. Mae good banter, fi wedi gwneud ffrindiau Cymraeg eto, a chi yn ffindo hefyd yn yr adran. Mae pawb sy'n siarad Cymraeg yn dod at ei gilydd. Stopo ar gwely eich gilydd, chi'n clebran am bethau, chmod. A fi'n credu hefyd, chi'n cael mynd lot o help i fynd trwy beth chi'n mynd trwyddo, gan gofyn bethau yw bobl arall. Mae'r gofal fi'n cael, amser chi yn yr ysbyty, mae'r gofal chi'n cael yn gret.
Thanks very much. Really, really impactful. I just want to say thank you to Nia in particular, who has a particular objective as a lay member of the JCC to reflect on how we are developing services and commissioning services utilising the Welsh language. And I think it's really important that there is a focus given to our fellow citizens who speak Cymraeg, and really important that we are thinking through what's our commission responsibility. And that's obviously a really important issue for providers as well. Susan, any reflections from the committee?
I think for me, it's we have such wonderful patient stories. Wonderful in the sense that the you know, whatever the difficulties, you know, NHS staff working with the patient, engaging with the patient, find ways through. And I think this is a wonderful example of that, but also, of course, that ability to speak your mother tongue and, you know, what it's doing to healing and recovery processes.
Any other thoughts or reflections? Abby, then.
Thank you. It was a really good patient story to bring, so thank you, colleagues, for bringing it here. And completely agree with the last point you made, Susan, about people speaking in the language that they is the language that they've grown up with and use day in, day out. But I think there was another reflection for me about the number of people who are with us for a long time in terms of the care that we provide. And he was describing the family, and we are, it just as a reminder of, for many people, we are involved in their lives for considerable periods of time, and when they're at their most vulnerable, and when they need a strong response. So I thought it was yes, the Welsh language, but that wider piece about the importance of the services we commission and provide.
Now then, Karen.
And I think for me, on that wider piece as well, you know, obviously the patient was telling his story around, you know, being moved on to home dialysis, and you know the difference that can make to somebody in terms of their quality of life, but also then that there is still wraparound support that people can call on. You know, you're not just left alone when you are moving to those more home-centred levels of care.
Thank you, Karen.
Yeah, and I think just finally the you know, the patient was able to attend QSOG last time, and so that was good. So they you know, had a much fuller discussion than just the short video that you've seen. Again, I think it's really important to show the joint working that both the quality team and Swansea Bay have done, and he was a great character. So they spent lots and lots of time with him. And you know, and it was great. It was a really good exercise, and hope that we've been able to bring something to the committee today to share that story with you.
Yeah, it's just a flag that it was an excellent story, but just a flag that whilst we heard somebody really positive, the patient, whenever they come, in particular, whether we see them or not, are also able and supported to raise issues that perhaps the things that haven't gone quite so well, they weren't big things, but to that patient, it made a huge difference if we could have dealt with X, Y, and Z. And what was nice was the way in which those issues were taken back so that we can pick them up through a commissioning perspective.
Thank you, Shamim.
Sorry, I put my hand down because I was going to say the exact same thing. It was nice that we were able to speak to the patient and hear some of the things that we could have done better, which was taken away.
Yeah, just to thank the patient for coming to QSOG and for the story as well. It's really powerful when you hear the stories from the patient here, and just remind us of how important the services that we commission are, really. And just to bring a little bit of attention to in specialist services, generally speaking, the patients are known to the NHS and have been known to the NHS for a really long time, and thinking about how we maximise the use of pathway commissioning to enable some of those better, greater patient experiences, but also to pick up some of the things that you raised, Mandy, I think is really important. Yeah, so thank you very much.
Great, thank you very much. Let's move on then to item 3. And first of all, in the section around delivering my apologies, Paul.
I'm just avoiding me, aren't you? I'm sorry we haven't got a video. I feel sort of somewhat underwhelming now. I'll take the report as read. Just a couple of things that I think deserve flagging up. We were looking at the risk register and the way in which the risk around the ambulance services was described, and it talked about reputational and regulatory impact, and struck us that although the patient outcome is sort of implicit in what we're reporting, the language matters. And the language we report in the risk register matters. So we have redescribed it to bring the patient outcome and the patient experience much more up front. And I think that's really important. Focuses attention. I know that will be reflected in ongoing reporting the risk register. The only other two things we'll come on to the finance and the financial sustainability. We talked about ambulance reporting as well, and it's not a criticism, but it's with the new model of standards. It's sometimes difficult, we felt as a committee, to get a handle on what's happening. The old reporting regime was quite straightforward in terms of performance against REDs, performance against handover, and with the evolving new model of service provision, we need to keep an eye on the way in which we handle the performance reporting, and I know that's an ongoing process. I've had discussions with Ross, and I know that he's picking up with WAST as well. And just only the third thing to note in terms of the IMTP, conscious of the clinical strategy and the timescale around that. Colleagues around the table will know my scepticism around both the helpfulness and the timeliness of the clinical strategy. Don't know what the timescale is on that, but we would hope that we might have some key messages on that, along with the planning guidelines that's able to inform the IMTP this year. We think that's really important. Last thing we want to be doing is preparing an IMTP and then having a clinical strategy sometimes around the middle of next year that might have important messages. So it's a key issue coming back from the committee. And I'm sorry, I'm not more visual in the way I portray that. But thank you, Chair.
You are wearing a very nice tie. Any questions or comments on the upward report from the Finance Plan and Performance Committee? Rachel.
It was just a comment, really. Thanks, Paul. Just in terms of your comment around ambulance performance. I mean, we don't see the reports that go to you as your committee, but we've been doing quite a lot internally to try and improve the way we report to our board and the metrics that are important and clarify, as you say, the kind of patient journey, the outcomes. So if there's ever anything that we can work with you on as a committee, happy to do so. And I know we had a conversation, Claire and Stacey, didn't we, yesterday in our kind of joint exec meeting on performance measures. So happy to work to do more and to get that better where we can support. Thanks.
Yeah, if I can just come back. Thanks, Rachel. I mean, the performance report is broadly the same as comes to full board. The one we've got today, it will be sort of a month behind or a month ahead, depending on the meeting. And I said it's striking the balance between the very detailed report that I know you as a board will be getting, which will have all sorts of internal operational detail. It's isolating the things that we need and the things that we need to be reassured of in terms of the performance we're commissioning for. So it's striking that balance between your needs and our needs.
And making sure that ours comes from a commissioner perspective rather than a perspective, although there will be an interface between that. Any other points for Paul? Thank you, Paul. Let's move on then to the delivering the plan section and item 3.1, the financial performance report. Stacey.
Yeah, I'll take the report as read, but for noting that we at month 3 we delivered a 1.3 million underspend to month 3 with a forecast underspend of 487,000 to year end. The details of the variation at month 2, where most of the data is based, is included within the report, and happy to take any questions on that. To note that we have had a detailed discussion on the £16.2 million plan approval uplift as part of the JCC 26-27 plan this year, and we will bring some further information back later on in the year when we've done some work over the summer. And this position does include some positive news in that regard, because we have delivered some in-year savings with some of our contract renegotiations, particularly in our NHS mental health providers. The report does note some risk, particularly around the early months activity in relation to transplant activity and some cross-border activity, and also some one-off high-cost mental health cases that we'll keep close monitoring of over the summer. Let's take any questions, Chair.
Thank you. Questions or comments? Or anything you wish to?
Yeah, just to say sorry about that. My battery was getting low. My laptop. I think it's a really helpful report. Lots of good detail. I think the main concern for me is in terms of a clear line of sight to what we need to deliver on the 16.2 million. I think we've got shared concerns around that, the achievability. There's at the moment, I don't have a clear narrative that takes us to achieving that at the end of the year. Recognise there's a lot of work going on, but I think we've still got a way to go on that. I think we've got quite a few challenges. I think the major concerns I have are we need to be clear about the risks in there, and also the elements. There's lots we don't have necessary control over. We're subject by the very nature of the services we commission to quite a bit of potential variation. We can have quite expensive cases coming in, which can throw askew the best will and best intentions. So I think it's important that the various strands of work that we've got to try and pull things back, we pursue with vigour. And I recognise the limitations on capacity, but I think it would be wrong of me as chair of the PPF committee to say I'm reassured that we're on track. I think we've got some significant challenges in there.
It's worthwhile just mentioning for these minutes that we've had a detailed conversation in committee around financial resilience earlier this morning. I think that there's further work required over the course of the summer to bring back an updated report in September, examining where the opportunities are. Yes. And we had conversations about that this morning to close that gap, but also where are the risks and what further mitigations might be needed. I think that there was a general acknowledgement that a significant amount of risk still exists. There's been some change in that, which is really positive, but we just need to make sure that we are being laser-like in terms of with some rigour behind the conversations that need to take place over the course of the next couple of months. And I know that your committee, Paul, will also be contributing in terms of scrutinising that.
We will, and I'm conscious of the sort of march of time we've got summer coming across. But if we can use the subcommittee to, even as a single item agenda, to really focus in on this, very happy to do that.
I'm conscious we've already had the detailed conversation, but are there any other observations or comments from anybody in relation to the first quarter financial position and financial resilience?
Sorry, just to follow up, Chair, to say, I mean, we always recognise that this was going to be challenging, but the commitment is there. And I'm cognizant of the fact that, chief execs have also got their own internal provider challenges as well. So it's not an easy task around the table generally. Recognise that.
Thank you. I see another hand raised. Just to give them an assurance, we've had a very detailed conversation about this already. Anything else? we move on then to the performance report? Again, back to you, Stacey.
Yeah, again, take the report as read. Just I'll bring in any of the commissioning directors if there's any points of detail to discuss, but just to note really the specific matters for consideration around the neonatal quality assurance meeting on the 6th of May, the inpatient total waiting list for plastic surgery, and the forecast reaches there potentially of 104 weeks from June onwards. We will close eye on that. The update since the PPF committee in relation to the cardiac surgery service and the escalation to level 2, and the action plan that's been put in place around that that was due by the 10th of July. And then just to other notes is around the level of outpatient activity for our cardiac surgery and paediatric surgery specialties are somewhat lower than at the same stage last year. We've talked about the changes in the escalation, the finance position, and then it's just if there's any items specific noting, bearing in mind that the report has already gone to PPF, and we acknowledge the questions around the Welsh Ambulance performance targets as part of the reporting mechanism.
So let's open this up for any comments or questions. Perhaps we do it by service area and start off with specialist services. Anything in particular? I just got one in relation to looking at services in escalation. Plastic surgery has been in escalation since 2022. I know we've had this conversation before, but what's the plan? Because we can't have a we can't have a service in escalation for so long. We need to be thinking about what if action is taking place, it clearly isn't having the impact we need it to have. So it'd be good to have that conversation, Carol.
Yes, so I guess Mel will be able to give a little bit more detail. So initially the service was put in escalation because of a particular provider. However, we then received notification from that provider that they were no longer able to provide that service. So actually, you could argue whether it should still be an escalation. However, there are actions being taken in order to consider a service to take over from what used to be in place. So I don't know whether Mel wants to.
Yeah, no,
So Swansea Bay is the provider. Plastics.
Oh, sorry, I thought it was the provider we had in the north. Yeah, sorry.
Yeah, so Swansea's not in escalation for plastics. It's like a low level. So it's like the monitoring because of the activity levels. Yeah. So that's the monitoring against the activity. You know, we haven't at the moment. We haven't got a sustainable plan for achieving it, and those are the things that we've been working on together. This goes back to the utilisation of the planned care funding. But as you'll remember, last year we were looking at we've got a lot of pathways that feed into plastic surgery, and most of those sit within secondary care, dermatology, breast, etc. And that was part of the rationale for the repatriation conversation that we had last year. So obviously the decision was taken to retain that within the JCC portfolio. That means that we don't have the control over the pathway in order to be able to manage that as we move forward.
And it's helpful to have that detail. I just there's a point for the committee in terms of our oversight and governance, that when we see that there is a service that's been in escalation for 4 years, I think there's something there in terms of, you know, what you said is actually helpful in terms of it's actually progress has been made, but it's about long-term sustainability. What I'm hearing, it'd be useful just to have a bit more of more detail provided, but also what's the pathway out, because of we need to be clear in terms of where the opportunity sits for that no longer to be an escalation, and whether a review has been taking place recently to see whether or not that will need to be an escalation. Abby, you might.
Yeah, I was going to pick up exactly that point, and I suspect we could probably identify the services got sustainability issues that aren't in escalation. Yeah. So it's being really explicit about why this is different, and would require level 2 escalation. So I had asked the question of my team before I came this morning, and I think it would be very helpful if we could find a way through.
So let's take an action to have a bit of a review on that particular service that is appears to be an escalation for some time, to see about what further action might be necessary.
And then the North Wales service at MWL is also in escalation, but that's linked to the level 4 escalation for plastics for Betsy within Welsh Government, and it's related to the opening of the Connors Quay service. I can see Carol's put her hand up, but that's imminent, as I understand.
Okay, brilliant. Thank you. So let's just, again, any other issues in terms of specialist services? Rob, and then Carol.
Thanks. Yeah, just wanted to ask a little bit more about the cardiac surgery escalation and the response. In the report, there was about 5 factors all accumulating into this position, I guess. Just wondering what the emerging action plan is, please.
So we've only had the action plan in the last few days, so the commissioning team is currently reviewing that and working with the provider, and we'll bring an update next time.
Okay, thank you.
Carol?
Yeah, thanks very much. I'd welcome a review of the escalation process, actually. If I think about the plastics one, in relation to that, the original issues are resolved or back in the business as usual. It's now the handover of the contract and the ongoing arrangements that's subject to discussion. And they're not at the highest level of review and scrutiny under our intervention levels any longer. So that would be really helpful, because I agree you can't continue to have something in escalation for that period of time. I'm satisfied actually that there's been really significant progress in this area, and that we are operating now as normal. And the Connors Quay development is open and has been running. So yeah, thanks very much, Chair. That would be really welcome. And perhaps we could have a specific meeting with the senior leaders to resolve that by the next meeting.
Yeah, let's take that, link the two actions together, which I think is very helpful, Carol. Carol?
Yeah, and just in terms of the escalation process itself, that framework is being reviewed. Okay. So I think some of the helpful conversations today, we can go back just to make sure that we really are explicit in terms of how services are in escalation and any narrative that can help get them out of that, so we're not having them in escalation for such a long length of time.
Really helpful. So let's move on then to see if there's any issues everyone wants to flag in relation to mental health. No.
Yeah, it's on page 5 of 13 or 78 of 269 pages. I did send a little note to Sue, because I thought perhaps I was just misunderstanding about the bed occupancy and the purchasing of additional beds. So I don't know whether, Sue, it might be helpful just to provide the explanation that I had. I thought it was what it meant, but it's really not very clear.
So
it's not, and apologies for that. I think it's in relation to the reference in the report where we say that it's worth noting that in some instances, due to the patient clinical picture, that we fund more beds than are actually occupied, and that applies to NWAS, which is the CAMHS unit in North Wales. And I think just to give some context to what was intended to be communicated, is that within our contracts with NHS providers, there isn't an inbuilt facility for additional packages of care, but there inevitably will be some patients who present with really complex needs and require more staff oversight and more observation and care than would ordinarily be present on a one-to-one placement arrangement. So what that was communicating is that within NWAS, which is the CAMHS unit in North Wales, whilst occupancy rates look low in terms of actual bed occupancy, there are arrangements intermittently where patients with really higher requirements in terms of their care are admitted, and that is balanced against the occupancy by taking on board more complex cases.
Okay, that's a bit clearer than what is that's helpful. Thank you very much. Any other issues that people wish to raise around performance report for mental health? Anything for then ambulances and 111? Nick.
Sorry, I was a bit late with my hand up. So there's there's been a lot of references, I say a lot, a number of references this morning to additional funding, whether that's through the planned care recovery monies or elsewhere, and also a number of references to services that are commissioned that are in escalation levels. I think it's important to note, and it's probably they're slightly linked in some respects. Health boards will be receiving monies to support their planned care recovery plans. They've all submitted plans as of the last couple of days, with a full plan due in on the 31st of July. There are a number of services that you are provided through JCC where we have 2-year waits or approaching 2-year waits, which are the clear priorities for the utilisation of recovery monies in the first instance, but they come with conditions around efficiency, productivity, modernisation and transformation. And I get a sense from reading the reports today that some of that modernisation and efficiency and productivity would be beneficial in specialised services that are commissioned through the JCC. And I'm interested in whether, one, health boards have flagged JCC services as part of their recovery plans. I haven't had a chance to read through them all yet. And secondly, whether there is a modernisation transformation plan for a number of the specialised services that are in escalation.
But thanks, Nick. I think that we've had a brief conversation the earlier part of the meeting, but Stacey, do you want to give a brief overview in terms of the communication that we've had with our main providers of specialist services in Wales around this particular point?
Yeah, so Nick, we are, or I didn't realise actually that you'd received some plans, so that the deadline was the 31st of July. So that's to be noted, and we are planning on linking in with our provider health boards to ensure that anything that is commissioned by the JCC we are notified of, and that we are part and parcel of those plans and delivery of those weights. There is something around though where that is in NHS England, because that's a slightly different scenario that we are in. So maybe we could touch base on that. And then finally, in terms of transformation and modernisation, I think around we need to work a little bit more closely with health boards on some of that. So I'll hand over to Mal if there's anything more, but my true reflection is we probably haven't got loads of details plans on transformation at the moment, but I think we need to have a line of sight of where those productivity gains are if you've got it there in Welsh Government, Nick, too.
Isn't there also the strategic reviews and the deep dives about the whole intention of that particular youth activity is around driving transformation and productivity and service reconfiguration and change? So we'll come on to that hopefully in Julie's report shortly, but I certainly see that as being the catalyst, the enabler for that transformation to take place. I guess the link is about how do we make sure that happens in the context of the services that we commission, but also then the clinical pathway within health boards, where actually that there is sometimes a disjointedness between the services that are commissioned by health boards and the services that JCC commission. Nick, is that the sort of the point you were trying to sort of tease out from us?
Yes, but I clearly haven't made the point effectively. I think most of the services that are referred to are provided in Wales. We've got clear evidence, all the health boards have got clear evidence that there are sufficient productivity, efficiency, transformation gains to be made across the board. Doesn't necessarily refer just to specialist services, it refers to the majority of planned care services. And they need to be delivered before money is accessed to support delivery. The money is there partly short term to deal with longest waits, but more formally to deliver sustainable services as we move forward. And you know, there's been a lot of reference in this meeting to sustainability of services. A lot of that needs, you know, a transformation or a modernisation approach before that we can start to look at additional funding being placed. So I think the onus has got to be on the health boards. I take Stacey's point about, yes, Welsh Government have got access to lots of the data, but that data is health board data. So it is all available out there in terms of the current level of efficiency gain that could be sought by health boards and providers across a range of services.
Yeah, thanks, Nick, really helpful. Paul.
Yeah, no, so just picking up on that point, I suppose there's two angles to this, aren't there? There's us as JCC sitting here as commissioners and being clear what might we want to try and deliver in terms of performance improvement, and then there's the providers side of this equation, which will already be being considered, I'm sure, as part of their own wider elective care sort of improvement programs. I was just thinking maybe, Chair, what this conversation flags to us is perhaps a need to go back to CCLG, so with the health board reps in CCLG, to ensure that we are factoring in any requirements that we might be thinking about around this resource, to make sure we've collected in those needs from our commissioning sort of perspective, but also, as Nick's highlighted, just to sort of challenge to say, and are we confident that the improvement and transformational change activities being undertaken in the providers that would justify putting in a request for that funding? So I think probably from a health board perspective, it needs us a conversation back to the reps who are on the CCLG to make sure that that is being considered as part of the deliberations for this resources as part of wider health board submissions. Thanks.
I guess from the perspective, which I think is really helpful, how as a commissioner we get an assurance that the services that we're commissioning are going through that rigorous process for those that we commission in Wales. And I guess that's where there's a disjointedness, and I don't know where in CCLG the place where that happens.
Yeah, I think it's worth us having a conversation at CCLG. There's two ends to that, because the one is there's the whole prevention agenda around transformation. You'd like to think if there was to the left pathway transformations that improves care, then you actually prevent cases largely get into specialist services, but also there will be areas where the cost effectiveness benefit is to have your specialist service far sooner in the pathway to get the best of the patient outcome. So I think there is a two-lens approach to some of that, Paul, and I take your point. I think we need to thrash that out a little bit more. I think with CCLG and exec leads, where it in a more sort of detailed, in a more detailed way, really.
So let's, if people are comfortable, let's take an action that we will look to engage this conversation about the Commission's level of assurance around the transformation processes within those services that we commission, acknowledging the prime responsibility of that rests with the boards of the health boards. But what level of assurance are we getting as a commissioner in relation to that process of transformation? And whether or not there's anything further that we need to do as the Joint Commissioning Committee to get that level of assurance. People comfortable with that? Yeah, Mel?
And I think that we just want to note that this year, for the first time, we have asked all of our providers to make 2% productivity and efficiency savings. So part of the work we do together will be on some of that transformation and modernisation of the services we commission.
Right, Nick, thank you. That was really helpful. And I think that was useful to make sure we've captured that in terms of the Commissioner's responsibility for that level of assurance. Any issues in terms of ambulance and 111 that people want to flag?
It may be my misunderstanding or misreading of the table that we've got at the page, top of page 7 of 13. I'm not sure I quite understand the metrics there, particularly in relation to the number of 999 calls and the stark difference between month 2, 25 to 26, and where we were reporting around month 1 to 2, 26, 27. So it may be that outside the meeting I need to understand that, because that looks like a doubling or near doubling.
Yeah,
is it winter pressures or?
Claire, can you help?
Yeah, I think I'll need to pick it up and come back to you if I can.
Okay.
Mandy, a significant difference, isn't it? Absolutely.
It's
Thanks.
significant, and I think it may just be my misunderstanding of the figures, but given all the clinical hubs and all the work that we're doing, it just doesn't look quite right. So thank you.
Thank you, Rachel. I'll bring Paul in a minute.
It looked a bit to me as if one of the columns was a 1 month position and the other column was a 2, adding 1 and 2 months together.
Cumulative.
So I think that was my reading of it.
Take this away and come back with some a credible answer. Paul, then Rob.
Yeah, thanks, Chair. I guess a couple of things I was just reflecting on in that data as well. The 111 website activity seems to have gone down from this year, month 2, from last year. Sorry, from last year to this year, we seem to have seen a reduction of about, I think it's about 17% in online 111 activity. And I guess I was just interested, Rachel, from a perspective of trying to divert more people to a digital front end, that feels to me like the trend's going the wrong way. We should be trying to get more people to use the website as a front end rather than dialing in. Was the first point. And the other point was, I know we're still settling down with the new criteria and the way we're handling, but we have still got some very long waits in the non-urgent requests. And I guess if you were to look at the 90th percentile responses for now and soon, we've still got. I'm not sure people would necessarily class 5 hour 50 maximum wait as a now, or a 15-hour wait for or 11-hour wait for a soon. But I think it seems a bit of a long criteria. So I suppose it's going back to Suzanne's earlier point about, we're seeing big improvements in ambulance handovers, and are we? I'm still not correlating improvement in ambulance handover with significant improvement in ambulance responses, and I think we perhaps need a bit more of a understanding of how's the utilisation pattern changing with the improvement in handovers. Is it that there are improvements in some areas and that's allowing an ambulance is being pulled into other health board areas to try and support in other areas? Is it just return to base? Is it all, we've been around that loop several times. I know, Rachel, and lots of conversations, but maybe it might just be worth a bit of a reflection on how's the new system bedding in, what's it seen in terms of response, how's it impacted with handover times. It just feels to me like we could do with a bit of an overarching one. And my final point was also on NEPs, just seeing the abandonment, aborted journeys, sorry. 11% aborted journeys, that again feels quite high. And is it that we're not booking people appropriately? Is it we're having people cancelling their appointments, that they didn't need the transport? I guess it's just all of these things are about how we getting best use out of the resources we're currently deploying, isn't it, really, and trying to make sure that we're getting the best capacity. So sorry, a few questions there, Chair, from me on the ambulance performance.
Thanks. And just check, Rob and Nick, your points both in relation to ambulances as well. And I'll bring Rachel and Claire in. No, it's not. Okay, Rob, I'll go to Nick then if it's in relation to ambulances.
Yes, yeah, so I totally agree with Paul's points. I think this table would benefit from a breakdown of either regions or health boards, because there is a huge variation, in my understanding, between the now and soon incidents and the correlation with handover delays across different regions. So just to pick up Paul's point, so in the Cwmtaf Morgannwg region, the number of handover delays has dropped consistently, and I think consistently is the right word we need to consider. Yet they haven't seen a significant improvement in the now and soon response times in relation to that, whereas in other areas of Wales handover rates haven't improved. So I think it's important that we see a local or regional breakdown of that. And just 2 other very quick points. The table would also benefit from the number of NHS 111 call volume compared to website, because I think Paul's point is right, but it doesn't, we're not seeing whether that's related to people now calling rather than going to the website, because the website clearly needs some work. And then my final point really is around now and soon. The delays to response is far too long, and the majority of people who phone the ambulance service are in these two categories. So there was a comment earlier in the meeting about the difficulty in perhaps understanding ambulance performance. Now we've got a purple category, but actually we should be focused on these two sets of incidents because they are, and Rachel, correct me if I'm wrong, about 90% of all 999 calls. And that is what is then reported in the public domain as I've waited hours for an ambulance, because they don't differentiate between they're a purple or a red or a now or a soon. So I think we need a real focus on those two incident levels, because it is 90% of the problem.
Thanks, Nick. Claire, let me bring you in first of all, because in terms of the data that we're providing, it's JCC data. So in terms of coming back in terms of some of the additional requests that are coming in to understand this data a bit more, can you respond to that?
Absolutely, thanks, Chair. Yeah, all really helpful points, and as a team, we're absolutely at this point in time looking at the performance metrics. What we're collecting, is it telling the right story? So that's played beautifully into that piece of work. So thank you for that. In terms of Paul, you were asking about, are we reporting on handovers, and we do that weekly. But you're absolutely right; it doesn't sit within this report, and I think we can remedy that for you moving forward, as well as picking up then on some of the more regional and health board footprint asks. Absolutely, and I think that'll give you a richer picture, as you said, in terms of the changes that are happening across the system, so that can be localised. Nick, you mentioned the 111 aspect, and again, I'll chat to the team in terms of what we already collect and how we can add a richness to this report through it if we have that data to our hands. So, but hope that covers many of the points, Claire, and I'm happy to pick up outside of the meeting in terms of the detail that we now need to reflect in this report moving forward.
Thanks, Claire. And timescales for updating the report or changing the approach to reporting.
So we're doing that piece of work right now. We'll fall in with the changes hopefully being reflected into the next performance report. So hope that works for you. Okay.
So at our next meeting, we should see a change in the approach to reporting.
Thank you.
May I just caveat with the so colleagues will be aware that we are in the middle of a strategic review of ambulance services, and part of that we are going to look at from a commissioning lens what the performance indicators look like, notwithstanding all of the indicators that committee are asked to be reported on. But there is something about making sure that we are iterative in some of that, depending on the outcomes of the review.
I think it's really important, and again, that we are reflecting what data we need to see as a commissioner in order to get assurance that what we're commissioning and paying for is meeting the requirements that we've set out as a commissioner. And I think there's a real risk, isn't there, sometimes that we then look at data that actually is about the provider providing a service, and of course there's an interface between that. But I think it's really important from a commissioner lens that we're clear in terms of what we need to see to make sure that we're getting the level of assurance that we need. So I really welcome the fact that these conversations are taking place. I don't think it's right currently. We need to make sure that as we go through this process of the strategic reviews around a range of our significant services, that at the same time we're saying what data and information do we need to make sure that we're holding to account those that are delivering those services on our behalf. So I think it's really important that we do that. Rachel, then Nick, and then Abby, and then Paul. Then I'm going to bring Rob in because of your point's a separate issue. Rachel first.
Thanks, Chair. So yeah, just in response to a couple of the points that have been raised, some of them I think easier to answer than others. So just in relation, Paul, to the point about website hits, we have deliberately in the last year probably stopped promoting the websites as heavily because the symptom checkers were so out of date and kind of clinically not right anymore. So we were concerned, and there was a risk noted in our board register about that. So those new symptom checkers have been developed and are going live in September. After which point, I think we'll definitely be much more proactive at actually sending people to the website, because, as you say, the digital front end has got to be the answer to what, not the answer, but a part of our strategy. So that, I think, will explain to some extent potentially why website hits are lower than they have previously been. Just in terms of NEPs and the aborted journeys, this is largely related to to crews who turn up to patients and the patient doesn't require the journey. So loads of good work, I think, going on in those collaborative spaces that we talked about earlier with health boards. I know we've done work with Halvar, for example, to link their patient record system with ours, so that we can see when appointments have been cancelled and transport no longer required. That's had a massive saving in terms of reduced numbers of aborted journeys. So absolutely work that we should be working collaboratively on that one. In terms of the kind of the EMS and the 999 service, agree with all the comments that you've raised, and Nick, that you've raised as well. And as you say, Nick, now and soon is the vast majority of the patients who ring 999. So I think there's a couple of things for me. One is that we know that there are some improvements we need to make and tweaks in terms of the new system that we've introduced, the new model, and that's work that's going on within the organisation through the Clinical Model Transformation Board. We are also doing some work on productivity that we've talked to the committee about before. So, for example, really upping the ante in terms of productivity of some of our Band 7 advanced practitioners, so that they can see many more patients. And that's particularly supporting then the soon category. So we'll get to more of those in a more timely fashion, and also reduce conveyances then to EDs. So there's work in both of those spheres. But I think what I was wondering about, and Claire, I can pick this up with you and Ross outside now, is that it's probably timely for us to provide an update of where we are in terms of the new performance framework, the new model, and provide you with a kind of a more comprehensive view of what's gone well, what are the things that we still need to work on, and what are the things we're going to be needing to work with you collaboratively from a health board perspective on. So happy to do that.
So thank you very much for that, Rachel. Really helpful. So two quick sort of reflections from me. One is, I think it'll be really useful to have that at our next meeting, if possible, just an update in terms of the implementation and where the risks and further opportunities might be. Secondly, for you, Claire, I presume all of this anyway is being considered as part of the ambulance and 111 strategic review, that again we'll be looking to report back in September as an interim, and then a final review in December. Can I just get confirmation that's what I said is true?
Absolutely, yeah. Thanks, Chair.
Okay, thank you. And Nick.
Yeah, so my point's related to Stacey's point and your point there, Chair, in terms of the review of ambulance services. I think the committee needs to be really, really clear what they are commissioning WAST to deliver. We seem to have a rather fragmented approach to the delivery of urgent and emergency care services across Wales, treating 111 sort of separately from 999 and then non-emergency patient transport services. And the difficulty, I suppose, is if you're Health Board A as a commissioner and you expect to commission, I don't know, a 2-hour response, an hour response, a 45-minute response to a now incident, which is good quality commissioning, yet your health board as provider is then holding 12 ambulances outside for more than an hour on a daily basis, then you're in effect disabling WAS from being able to deliver their commissioned service, alongside the fact that we've got different pathways across the board for a number of services, whether that be the output from 111 and how patients get access to services after phoning 111, and the need to be really, really consistent in what it is we are commissioning for quality and safety of the population through an urgent and emergency care service. And it's disappointing to read on the risk register and the delivery confidence rating that we've still got challenges with that ambulance and 111 review that's rated as a medium, when clearly it is a major safety risk in the system. So I would just encourage JCC to be absolutely clear on what it is commissioning WAST for, to move away from the sort of financial contracting approach into a commission for quality, and health boards need to take responsibility then for enabling WAST to deliver their commission service.
Thanks, Nick. I'll come back to this at the end, Claire. Rob's been very patient on a separate issue.
It almost seems like a minor issue now after all that debate. All I was going to ask if the performance report could include, rather than just trends to last year, comparisons with commissioned levels, so we can see how that's moving in year. But given the recent debate on WAST and emergency care, I'll probably leave that one for another day.
All right, thanks, Rob. Claire, anything else you wish to say in summary in terms of the ambulance 111 section?
Only to conclude, as many others have really, Claire, in terms of the importance of that strategic review, the outcomes of that in terms of taking us forward in many of the domains that have been reflected here today. So just to give colleagues some assurance in terms of that work now starting to move forward. And the confidence rating there, Nick, was simply around us making sure we had the right capacity to move that forward, and we've now aligned the team accordingly.
Great, thank you, Claire. And again, I think this has been a really helpful conversation. Goes to the heart of our role as a strategic commissioner, and making sure that we are looking at that based upon population health needs that we have identified, but particularly looking at services for the whole of Wales, such as ambulances and 111, being really clear in terms of what we're commissioning, and then allowing WAST to get on and deliver that, but acknowledging the dependencies that exist with, as Nick has quite rightly said, in terms of particularly around ambulance handover delays, and enabling WAST to have the best possible opportunity to deliver the service, the specification and the service we expect them to deliver. So I think that the crucial thing is going to be, do we get as an outcome from the strategic review clarity around that, and that can then influence our commission intentions. Stacey, finally, wish to add.
Yeah.
It's gone broader than a performance report, a performance item, but be helpful, I think. Yeah, it was really helpful. And I'll take some of the discussions into PPF as well, particularly the ones around the actual report and, presentationally what we're reporting strategically, but also, just to stress the importance of the strategic review, really. Just a final point from me on the performance report in relation to work. Sorry, Abby, you go.
Thank you very much. I wanted to come back to a different comment, which is in the section to do with quality, incidents and complaints.
Yep.
There's a summary there. There's two tables. It says month 2 and then quarter 1, so there's just a discrepancy about which it is. But it would be really helpful to get an understanding of what those are. So they're by commissioner, aren't they? So they're individual health boards, but it get a sense of, did patients come to harm? Was it an IM? Yes. So what those are, and what we've learned from them, and how that's feeding back in, and which provider that relates to. And I guess similarly with the number of complaints, again, it would just be useful to get a bit of a sense of what were the things coming out of those complaints and where are they in the process as well.
Yeah, I know Carol wants to come in, but it is the idea of getting an integrated performance report that is all captured in this report, and I think there probably is a timing issue with some of the quality metrics and the way that they are reported. But Carol, do you want to come in?
Yeah, I think that level of detail, Abby, is sent into the QSOG committee, so we can think about how perhaps we can summarise some of that level of detail back into this report for future reporting.
So that's really helpful. And then the final comment was just about the activity. There's a line in on table 5, which is page 17 of the report, that just talks about the PET activity appearing to be understated. Yeah. be good to know whether it is or isn't, because it would appear that it's understated.
Yeah.
So it's getting line of sight.
Yeah, that's fine. No worries.
We'll come back on that. Okay, thank you. Just in terms of workforce, I know there's been some progress made in relation to performance reviews, but still to we have 60% of our staff have undertaken a performance review is not acceptable. And similarly, in terms of statutory mandatory training, 80% clients. Again, there's a lot more that we need to do. So that's something we are in control of as an organisation. So I think it's really important that we are focused on that. So I presume there's specific pieces of work taking place, particularly around the performance appraisals.
Yeah, so individual directors have had reports recently on the individual percentages, and we've all picked it up formally as part of our team meetings for a big push. A lot of it is linked to new starters and just the delay between somebody recruited, somebody started, and then, you know, having 3 months to be able to do their PADRs. But it's really important. It's something that's talked about in every staff meeting, and we will look for improvement by the next time. And Juliet is on the ball, adamant that this will get better.
Shamim, final comment in this section.
I was just going to say something about workforce as well. I'm glad the staying well plans have been talked about in relation to sickness, but in other reports we've had vacancy rates as well reported. I wondered how the staff team are looking in terms of capacity.
Good point.
Yeah, so I can only anecdotally say at this point that the vacancy rate is far less than it was, because I haven't got the numbers in front of me, and I know George's team reports on that regularly, so perhaps we can get something to you separately outside.
Could we include that in the next report as well? Because I think it is obviously in terms of can we deliver our plan, staff resources is a key element of that, and but also that we had a conversation about holding vacancies as well. So let's be cited on it as a transparency. Right. Great, thank you very much. That's been a really helpful conversation. Went slightly broader than the standard performance report, but really helpful. Let's take a 10-minute break. Come back at 12 minutes past.
That would be ABM. And the got sat together.
You're right.
Okay, welcome back, everybody. Thank you for coming back so promptly. We're now moving on to the delivering the JC second part of delivering the plan, and that's the progress against delivery at the end of quarter 1. And over to you, George. And again, assume you've read the report, but if there's anything particular you need to bring to our attention.
Thank you, Chair. I suppose a bit of preamble, if I may. We obviously submitted our plan at the end of March into Welsh Government. We did receive some comments and queries back for further information from them, which we subsequently responded to by the end of June. So we are still awaiting formal authority from Welsh Government on our plan, but nonetheless, we are progressing to deliver it, which is what this report highlights. So we did report a month 2 position to both CCLG and Planning Performance Committee, but that was obviously at the end of May. This report reflects the end of quarter 1, so all I can say really is that there's very little change. It reflects very much what was reported in both of those fora. And the report is split into sort of 2 sections, one which is delivery so far into quarter 1, but also delivery confidence for the remainder of the year. I suppose the only other thing that I wanted to sort of flag really for now in relation to what's reported here is that there is a general theme of availability of data, but also data analysis, and it reflects back on a comment and a discussion we had in our in-committee meeting earlier this morning around an ask of health boards really for any capacity or capability that will help us whilst we build our own internally within the JCC to make sure that we progress these at pace and pull back on any delivery confidence. I think we are looking to secure that. So it's a outright clearing for any support that can be offered. I will, if I may, come back at the end, Chair, to update on the development of our IMTP, but I'll focus on this report for now, which is progress against our current annual plan. Thanks.
Thank you. Comments or questions?
Can I just ask a point of clarification, please, in terms of the maximum deep dive review? Carol's been very helpfully keeping me up to date as the lay member that's attached to that work. I'm just wondering, because obviously there's work going on nationally with Welsh Government at the helm as well, do we anticipate that there potentially will be any delays that will have an impact upon delivery of what the JCC have identified in terms of actions to be progressed, or is everything on target? I'm conscious there have been delays already.
Yes.
I think you make a really good point, Mandy. We are involved in the Maternity and Neonatal National Programme Board. I think last time it's quite a lengthy programme board, and I'm not sure that level of discussion actually took place. So there does need to be that level of clarity in terms of the feeding in to the national picture.
I think for me, it's about whether anything that emerges from the national picture has a direct impact upon any of the activities we need to have included in the deep dive work and the actions from a commissioning perspective that we then need to take.
Or vice versa.
Or vice versa.
Yes, absolutely. I'm not sure that there's any specific work that is proposed at this stage that will have an impact, but it could be the other way around. I think you're quite right.
And having clarity around a clinical strategy will be fundamental, won't it, in terms of to know what collectively we are wanting to, what our ambition is on behalf of our population.
Particularly as the new pathways work, if I may come back, the document was not a plan. It was a lot of words, if I then dared to be so bold, but it didn't provide that clarity of the plan, in my view.
Suzanne, then Paul.
Yeah, no, thanks for that. Thank you for the report. I'm just, in terms of our role here, I just think it would be helpful within the report to describe what are the objectives of the outcomes of bits of work. I know we've all seen the PIDs, but actually when you come to look at this, I'm still looking and thinking, so what? What are we trying to achieve here? So I think it would be helpful just even if for each one we list, the key outputs or objectives that are being sought alongside any financial estimation that was, because if you remember, this started from our conversations around, in all regards, around sustainability and transformation, which slightly speaks to Nick's point earlier. And then I think the other thing that might be useful in kind of, because otherwise it's a bit of a cold assessment. I'm like, so it's amber, well, towards what, I guess. But the dependencies, key dependencies. So national clinical plan, for example, might be relevant in the neonate work. The regional partnership working that's happening in different health board areas. So certainly the work I'd be doing with Abby, or the work that we'll be doing in the South East. National interventions, for example, the 104-week transformation monies is a dependency here or an influencing factor that we should. It's kind of trying to take it into a bit more of a complex, sophisticated level of understanding. Otherwise, I think we could sail on with amber ratings, which is the danger, and then we don't necessarily understand where the intervention could have been made earlier in the delivery of the year. Helpful.
It is helpful, thank you, Suzanne. And I think it's tricky, isn't it, to present a summary of a lot of progress. So each of these, certainly the strategic service reviews, have programme boards that have detailed project plans and with that highlights critical path dependencies, etc., or at least will be in the process of. So, but yes, we will nuance that report and make sure that it's included in.
Probably don't need all the deliveries. I just need to know that they've been delivered. Yeah. Deliverables achieved. Tick.
Yeah, I mean, yeah. I think in a way we were trying to achieve what, not probably the overall outcome, but to show exactly what has been achieved in Q1, which is what we said we would achieve by Q1. So we're highlighting that. But I take your point that the more overarching objectives need to be reflected better in that.
And then the last point would be, I think, well, I don't know about others, but I absolutely know I haven't got any capacity to offer up that isn't already being offered up. Yeah. And I suppose it kind of speaks to our challenge, really. So what we have to work out is, if we just keep pushing around between us all, we need more capacity to make this work. The answer is there isn't any more, likely. What are we going to do that's different? Because otherwise we will still be pushing around. We need more help and we won't make progress.
And if it helps that Julian and I've been having those conversations in terms of we may require some additional resource or some expert resource in order to enable us to hone some of this down into a clear transformational plan and help us to start delivering that. Because I don't think that with all of the will in the world, taking bits of resource of already stretched executive staff in health boards is going to enable us to do this with the pace that we need.
Yeah.
So those conversations are taking place. Paul.
Thanks, Chair. I just wanted to go back to the point about maternity, neonatal. I would agree about the concern around the duplication or risk of duplication with some of the national work. We've made representations as health boards to that national work because currently there's no health board representation on that group at all. There's no director of nursing, there's no director of midwifery, there's no chief exec. Carol's the chief exec lead for maternity and neonatal services, wasn't invited to join that group. So I've had that conversation on Friday with Chris Clayton to say this, and I think from his feedback they're re-looking at that group to try and ensure that it is appropriately resourced with the right people in the room. Having said all of that, I still think we shouldn't wait for the national work to get on and think about what does the configuration of neonatal services need to look like, because we all know that we need to reconfigure neonatal services and we've been dancing around that for quite a long time now. And I don't think we should wait for the national work, which I think is probably more broad in its ambitions around quality, safety, culture in maternity and neonatal services, of which configuration will be part of those conversations. But as commissioners of the services, we should be really at the forefront of how those service models are delivered. So I guess I would agree that we need to be part of the national work, but I wouldn't want it to be a limiting factor for us not to start to do that work, to think about what does a configuration optimally look like across our work. And it goes back to Suzanne's point about, you know, some of those conversations are already being had regionally anyway. So I don't think this is going to be anything that anybody will not want to engage in. So I think we perhaps might want to just think about that moving forward.
Thanks, Paul. Carol Shillabere, anything you wish to add?
Thanks very much, Chair. Thanks, Paul. So I think this is really challenging territory around the configuration, and we've been round this particular roundabout for some time. I think bringing back the evidence base of what's been done, particularly in Scotland, is our starting point for us to understand what the real scope and potential impact of a very big exercise in reconfiguration would look like. I was just checking my diary because I think we've got a follow-up meeting, Carol, in the diary to check in terms of the timeframes and whether we can be on track for what we promised at the committee before, and therefore perhaps in that discussion we can have a look at options for acceleration and whether we have got to work in tandem with that other national piece. There is a huge risk of duplication, or that ends up with no one doing the work that really needs to be done. So thanks, Paul. I know we all raised a concern and you've been acting on our behalf as chief execs to make sure things are tied together. But that would be my comment. We'll catch up and have a look to see whether we can really reset a time frame around this and be really clear about the mechanisms for moving forward.
Thanks.
Yeah, I think that's really helpful, and I agree with Carol. We do have a meeting in the diary, and fortunate that everybody is able to attend that meeting. So I think we can take some of these discussions into that forum.
So, I know colleagues will appreciate this, and I'm sure that this will be heard in the way that it's intended to be heard. It's really important we deliver this in terms of the timescales that we've set, or to explain if we can't, and be really clear what is the reason why we can't deliver. Then we set out this when we agreed the service reviews in May, setting out the timescales that we would agree. And I think there was buy-in from everybody. It's disappointing to see there's a bit of slippage. I think it's really important that we catch up. And if there are particular challenges or issues like the conversation you've just had around dependencies, then we need to have a conversation as to whether or not they are so significant that we need to do something differently. But I'm in Paul's camp in relation to this. If we don't ourselves determine how we believe services should be configured, and taking that into and having that broader conversation, because there's other work taking place, we'll never make any decisions. So I think it's really important that we do this based upon what we've set out to ourselves. So let's just make sure that we just remind ourselves of the importance of that. Stacey?
Yeah, just to echo really that since Juliet have started, she has put in more regular reporting mechanisms around the projects, and we are now bringing highlight reports into our senior leadership team on a more regular basis. I think the aim is that we get that weekly, and that the conversation is focused around that patient outcome. What do we want to get out of it? Conversation in terms of the delivery of those services, and you know, kind of not just a how are we managing the contract type conversation. So I think the elevation, just to assure you, Chair, is that Juliet is bringing some of that rigor into the conversation. I think for me, there's just I can't leave the room probably without saying it, where there is data concerns or where we haven't got the data, I think we just need to specifically start to report that now into the committee or our other committees, just so that we are escalating that in the right way. I'm just conscious that we've had a data conversation for a long time now and it's still there. So I think we just need to just highlight that as a team where we've got specific issues around that, so that we can bring back what we need to. And I think there has been a conversation previously around, you know, where data becomes a constraining factor and then has an unintended consequence to the outcome. And I think there's probably a conversation that we need to have collectively, which is, well, how much data suffices then? Can we make the decisions based on the data that we have got instead of aiming for perfection?
I think maybe that's a balance that we need to probably, sort of, I was going to say negotiate on, but kind of a mitigation when we get to September meetings.
And if on the analytical support, which is touched upon, Stacey, if we can't get that resource from health boards, where are we going to find it?
Yeah.
And how do we access it? So I think that we may need to say that this is so important. We've got to get some resource put into this, and it's probably the wider conversation that I've been having with Juliet about the pace of and the scale of transformation that we're looking at in a number of areas, which we all know is absolutely necessary in order to improve the outcomes for our population, will require us to invest some resource.
Yeah. Organisationally, we need a bit of a data strategy as part of the broader strategy, and I think that can elude some of those conversations. But definitely for this year, there's probably some short-term bits that we need to have a discussion on.
Right, cool.
Just to follow up on that detail, that data, I'm obviously involved in work on the renal deep dive, and consistency of data is one of the key issues that we're facing. But there will be a point at which the resolution of data is so far off, we have to go with what we have. There is a point at which sort of we've got to avoid the excellent being the enemy of the good. And we have to go with what we have. Suzanne?
I think what would be helpful is to understand what is the data issue.
Yeah.
Is it not collected?
Yeah.
Or is it that some of it is partially collected and therefore we don't have confidence in its quality? Is it coding? So understand what not here necessarily, but understanding that in order to fix the problem or make the determination you're pointing at, which is it might be good enough to make a decision.
Okay, great.
So hopefully each of the deep dives and the strategic reviews will be doing their own analysis of the data they need and where the challenges and the gaps are. I think, like Susanna said, I think it's important to know, so what's the particular issue and how can we mitigate and overcome that? Any other points I wish to raise in relation to where we are currently with the plan after Q1? Okay. George, you want to touch upon the preparation of the IMTP for next year?
Yeah,
Just comes round quickly, doesn't it?
Yes, it does. No rest for the wicked. So again, nothing formal here, but we have taken further information through CCRG and Planning Performance Committee around the development of the IMTP. So clearly the outcome of the strategic review deep dives are going to inform a lot of what then is taken forward in the future plans, and there will be that focus on transformation, modernisation, effectiveness, productivity, sustainability. So we are in a process of, in fact, we have called for commissioning intentions both internally. They are being drawn together. We will take that back through CCLG once our senior leadership team have considered that, and we'll test that with CCLG. We've also started to review our process for prioritisation to inform the decision making when it comes to what is included as a proposal in the plan. And we are looking at an evidence-based risk assessment approach, which will replace our prioritisation and CAG for those who are familiar with those approaches that have been taken in the past. So Yolo's team are leading on that with support from planning. So there's a lot going on. We also, just to reassure everybody, that Juliet now sits on the National Clinical Plan Development Board, which is really critical because obviously whatever plan and whatever strategy we have needs to dovetail into that. And I'm also linking in with Samir on a very regular basis to make sure that we're aligned. And as Paul's alluded to earlier, the timescales of that may be a little bit challenging, but we'll make sure that we try and run those as contemporaneously as possible and make sure that they are built into and inform one another.
Okay. Thank you. Comments or questions? Nick?
We had quite a lot of discussion at CCLG, so obviously I'm sitting here for Hayley, but in my own right, I sit on CCLG as well, about the developments of the plan for next year and the strategic planning framework in which we would like to see that being cast. So a set of strategic commission intentions as well as service-based commission intentions, for example, the financial envelope within which we want the plan to be developed, And then quite a lot of discussion about involvement and that sort of thing. So I think it's sort of fair to represent that at the committee today.
Thank you. Rob?
Yeah, just following on from that point really is that the biggest challenges we've had this year are around living within our means. And we all know that the specialised services and the wider agenda around that are more expensive than our more regular services. But I think there's a danger that we just need to manage, which is not over specifying our commissioning requirements, because we can't afford what we're doing now in the round. So that reality check, I think, is important. There's obviously going to be implications of that. So I think being clear on that as part of the workup in advance rather than after would be helpful. So if we don't do something, what does that mean? I think having that clarity sooner and upfront is as important as the proposal itself.
Yeah,
Thanks.
good point. That's right. Okay, George, anything else?
Yeah, just to come back on that. So yeah, the points that both Rob and Nick have made from discussions at CCLG have been taken into account in the workshop we ran on commissioning intentions. So we will have some cross-cutting strategic commissioning intentions for across the board. And yeah, that realistic approach in what is available within our very limited and precious financial envelope is going to be taken into consideration.
Suzanne?
I guess there's a couple of things. So clearly we've got a new administration now in place, and there's something about their in priorities, and I've already had some experience of a discussion about priorities that would actually be a commissioning decision, haven't been decided to be commissioned. So I think there's something just around understanding what that looks like and the influence that doesn't have on a very tight resource. And, as I have repeatedly said, the vast majority of services that are commissioned within this arrangement, or there is a proportion, a huge amount of services are not commissioned in this arrangement. And historically, we discuss it here, they go on the should do list or anything beyond that, and that is the end of the conversation. Those patients don't go away because the money's short. So we really have to work out a better routine next year to manage that, what is individual health board risk, collective risk in this room, and then individual person and individual people's risk. And I don't know what the answer is, but I just don't think we've quite got it right yet.
Yellow.
Just to echo what has just been said, I think the difficulty will be that we've got a constrained budget. So I'm going to use it as an example, something that will come our way. So stereotactic ablative radiotherapy, SABR. JCC commissions for a specific number of indications: renal cancer, small cell lung cancer, oligometastatic disease. And NHS England have recently published their commissioning policy for SABR for prostate cancer. Now, if we think that that can't be offered in Wales, that's fine. But if we don't commission it, it'll come to IPFR. And if it comes to IPFR, the evidence base will be that we will then end up approving it. And I suppose I would like guidance from Joint Committee. The easy thing is just to put our head in the sand, but does Joint Committee actively not want to commission things? Because that is what we need to have a discussion about, because otherwise we will keep having things coming to us and the default will be IPFR.
Actually, I think that's a really important point. And interesting, that was one of the issues that came up at the evidence session at the Wales Affairs Select Committee around the additional burden on the IPFR process because of the lack of commissioning intentions. And hopefully this will be teased out during the strategic reviews and the deep dives, but it's a real issue. Mel, you're dealing with it all the time, aren't you?
Yeah, and it's that if we decide not to commission something or decide not to prioritise something. At the moment, that is not, as Yolo said, it's not a decision not to commission. And so, you know, where there's good evidence, then that activity and hence the patient cost. I mean, because these are things that would deliver good patient outcomes. So the evidence base is really good for them. So those costs will manifest in an unplanned way. So we need to make sure that if we're making these decisions, that it's a decision, a proactive decision not to commission.
Yeah. But the budget is set on the things we do decide to commission. So from a governance point of view, it's not really defendable, is it? Because we say, well, we haven't got the money to pay for those things. Actually, the decision in this room not to support a plan that includes those things and then pay through them for another route and knowing very well that is what's going to happen is not a good way to manage the resources. So I think we have to have a look at what should we be commissioning, what the benchmarks are for the people of Wales, and then what is the best value way of delivering those things. At the moment we work with, this is how much money we've got, what can we do with that? And you know, Rob's right, at the moment we're in a status quo, which is basically we'll stick with what we've already been delivering, a little bit of movement at the margins, but in a minute, Yolo's right, we'll have to be deciding not to do things, which is, you know, incredibly hard to do. Probably doesn't happen in reality.
Really goes to the heart of some of the things we're wrestling with. So I think it's important that we continue these conversations as we look towards the IMTP for next year. George, anything else?
I don't think so, thank you.
Great, thank you very much. Let's note the report and this will also be an ongoing conversation for the JCC over the course of the next couple of months. We come on to a whole range of items on governance now. Aaron, corporate governance report first of all.
So thank you, Chair. So the series of papers pick up on a lot of the conversations we've had already in the meeting today. So I'll share them for notes and then pick up questions with a couple of items. In the corporate governance report, just to flag that we've recently had, following approval of our terms of reference and standing orders, they've gone through health board approval and are now live on our website. An accountability report has been approved through the CTM Audit Risk and Assurance Committee and board and signed off and published at the AGM recently as well. Alongside that, then looking at how we continue to work with CTM as hosted organisation, we're still working through the updating of our memorandum of agreement with health boards and our hosting agreement. So fingers crossed that should be shared in September for approval. And it's looking as though it's going to be quite a light touch amendments just to reflect where we are as an organisation.
Thank you. Any comments or questions on the corporate governance report? Can we note the report? Right, thank you. Annual committee effectiveness self-assessment results 25-26.
Thank you. So this is part of the work we're required to undertake under our standing orders. There's updates on where we are against achievement of our recommendations from the 24-25 review as Appendix 1 and proposed recommendations and actions to take forward for 25-26. I think the two key themes to draw out for me, I'll take the rest as read and acknowledge they have been reviewed by subcommittee chairs and the ENS chair and for the SLT as well, but just take these forward. But I think there's a theme that's drawn through from both reviews, looking at the strengthening of our report writing processes and procedures. Juliet's now on board and it's something that she's picked up as well. She's asked my team to look at a best practice review of report writing across NHS Wales and into NHS England to see how we can refine what we're doing. But it also does feed into some of the conversations we've had, how we're looking to improve our performance report and the reporting we're doing from QSOC on our concerns and complaints. And I think it's going to be an iterative process because on the one hand, we're looking for a greater strategic focus on the reports we do prepare. Then we come into this forum sometimes and we're asking for lots more than operational detail. So it is going to be a fine balance to strike. So we'll try our best to get action throughout the year. But I think we do really need to focus on reducing what we do report, but really focus on the stuff we do then report is strategically focused and picks up the so what and the quality aspects what we need to do. So bear with us. If there is additional detail that you do need, we'll refer to that in the content of the report, I think, which we're trying to do. But yeah, we're trying to adopt a best practice approach to that to make sure it fits the needs of everybody.
So I think there's always a natural default, isn't there, that when there's a particular issue, particularly there's an issue that you have an interest in, when you seek more detail, I think that executive colleagues should feel free to push back to the committee to say, actually, this is not necessarily helpful in terms of our responsibility as a commissioner. Now, we may then have another conversation, but I think it's really important that we need to be disciplined as chief executives and lay members of the committee to really be clear of what data and information do we need that's been properly analysed as part of the development of a report to enable us to take appropriate decisions as a commissioner and not step into inappropriately the health board or the provider's responsibility for assurance around the quality of what's being delivered. We need to have an assurance around the quality, of course. Actually, it's the provider's responsibility to get assurance over what they're delivering. We need to be sure they're doing that. But that I think should frame the conversations that we're having in terms of what there's presented back to us.
Thank you, Chair. And only one other point on the effectiveness reviews. I think unfortunately, sort of attendance at subcommittees, the chief executive is going to be impacted following recent events and with attendees at PPF. But I think we're struggling for consistent chief executive attendance at those subcommittee meetings, and we've already touched on in the meeting that there's a huge pull on chief executive colleagues in a number of different directions. So it's just how we look to approach our moving forward. If we did look to revise how attendance is structured those meetings, it'd need a review of terms of reference which have to come through here. So I suppose we'd welcome some feedback from chief executive colleagues, really, how they feel that process works at the moment, and how it could be strengthened to improve our resilience as well.
I wonder, Paul, whether chief exec colleagues can have this conversation separately. I mean, when chief executives are present, I know from performance planning and finance, it's incredibly valuable. And by and large, either Abby or Hayley, before she was not in the organisation, it was really, really impactful and aided our scrutiny and our decision making. So I think that if we can maintain that, I think that'll be really important. And it maybe is the approach of having deputies that could fill in, chief exec deputies will be useful. But Paul, that's provoked.
No, very happy to pick that up with colleagues. I mean, there is quite a challenge at the minute, I'll be honest, about capacity in terms of being pulled into all sorts of work nationally, as well as obviously things that we're all doing in our own organisations and JCC. So I think a bit of flexibility, plus we've got a bit of change happening at the minute with chief exec roles. So but absolutely agree with you, Ian, about the need to have senior leadership reps in the room. I think if we're able to look at deputies being able to attend where necessary, that would be helpful and just spread the load a bit beyond. But we'll pick that up with colleagues about ensuring that we've got the right people in the right meetings.
Let's take that as an action again that you can then follow through, Aaron. Bring some more people. Any other issues that anyone wishes to flag on the committee effectiveness? No. Okay, that's then noted. We've got then two items in relation to risk. One is the current risk management process and our organisational risk register, and then moving on to that, our approach around risk management and assurance. If we deal with the current, first of all, Aaron, if there's anything particularly you wish to draw to our attention.
Just the organisational risk register, this has been through subcommittees for approval. I think Paul's touched on it earlier in the meeting, how we've, the PPF committee gives some real scrutiny to the proposed new ambulance risk. And I think that feeds into the conversation we've had in this meeting as well, how we're looking to manage the risk and manage the service we do commission. And I think touching on that, so we've added a new risk 96, which looks at the delivery and sustainability of safer quality emergency ambulance service capacity. I think that's with the ongoing review. Ross and his team have looked at how that risk is described, and I think that replaces risk 78, which is reported as closed, but it's just to place that more commissioner focused lens on what we are commissioning, what the risk is to us and how we manage that. Always bearing in mind, specifically after the feedback we had at PPF, that we need to make sure we keep the patient at the heart of that risk and how we manage it. So that's the one new risk there. Then on a positive side, there are also two de-escalated risks. One is risk 77, which relates to commission of sufficient emergency ambulance services capacity. Again, that's not saying our risk's gone away, it's just it's been reconsidered in line with our risk management processes and the score's been reassessed. And we've also seen some positive de-escalation of the hereditary anemia services capacity in South Wales as well. I'm happy with Commissioner Lee to take any questions on the other risks, but they're the key headlines.
Risk 96, which is a new one, it's quite wordy.
Yes.
I'm not quite sure whether it needs to be as wordy, but it may slightly lose the point of it if we had to read it about 3 times before I got it to sink in. But
that's anything I pick up with Ross and yeah.
Any other issues on the current risk register? No, go on. Yeah.
I mean, I think it sort of speaks to some of the work that you're doing, Aaron, but I think there's a lot of stability in the risks. They're not moving. So I don't know what that tells us. It either tells us our mitigation isn't really working because it's not bringing them down, or we have got the right actions in place. And it's difficult because some of these are quite long tooth, and you know, I have the same challenge in my own organisation. It is tricky, but I do, even if it's just a reflection that we've seen that, and that is something we're aware of and working to improve. And some of them will be more or less intractable in terms of structural or systemic issues.
And I agree with you, Suzanne. I think what's going to be really helpful when we come on to the next item, look at reframing our approach to risk and having a committee assurance framework. That's where it would be useful for us as a committee to be seeing, in terms of what we own, are we focusing our attention in the right place, and are we seeing a level of significant shift of movement that we need to see, and you know, and also as what we've identified as our assurance framework, is that shaping our committee agendas and also the agendas of our subcommittees.
I agree as well, and I agree with both comments. I think it's a journey we're on. I think I've been in close to 8 months now, and we've seen a reduction in the number of risks. And it's not about suppressing risks, it's just about making sure they're pitched at the right level and being managed appropriately. But we're continuing to look at actions and mitigations as you set out. But I think lots of risks, there's going to be some movement in this because risks are going to start manifesting themselves. I think as a MELS director, there's potentially 10, 11 neurology risks that are looking to push on and be moving studies. And I suppose as we continue to review them as emerging risks, that input that you just provided, then we can start pushing that back as well, saying, yes, we accept that there's pressure in the organisation, but have you considered what actions we're taking, what mitigations are in place? And it might be that those are amalgamated where they can be. So the risks then feed into the Joint Committee Assurance Framework, and how we manage those from a commissioner perspective, informed by patient harm and contractual management, starts moving those along quickly. So that's a lot of waffle, but I suppose the things in train that hopefully starts moving this along.
Thank you, Paul.
Yeah, just to follow on what Suzanne said, I think that's helpful, because it's an issue that has come up about PPF. Neo in particular has been quite vocal about this, rightly so. We've got things that have been there for quite a while, and it does beg the question, kind of, okay, what are we doing? Do we need to do anything? It just questions about how we handle and record those risks. Yeah, great. Don't have an answer, but
I know it is challenging. I agree.
Okay, we note that. Then moving on then to the I hope that in terms of this, the next item on the agenda, well, I know there's been this has been socialised and input from lay members with separate meetings, and hopefully there's been the opportunity to input from chief. Well, I know there's from chief executive as well. But hopefully there should be no surprises here. And this is part of an ongoing process that we've put in place around a different approach to risk, which has been fundamentally important. And I think that no doubt this will be iterative over time, and we'll look to amend this as a live working approach to risk.
Definitely, yeah. So a suite of documents, our risk management process and procedure, Joint Committee Assurance Framework, the reporting template that goes with that, which you'll start to see in September moving forward, and then our risk appetite statement, our risk appetite matrix, and what our proposed strategic risks are that we'll look to monitor within the Joint Committee Assurance Framework. So these have been endorsed by subcommittee. by SLT, having previously been reviewed by yourself, Chair, and by the lay members at what would have been our strategy day in June. We made the best use of that time and had a workshop to work through this. Following approval of endorsement of PPF, it was circulated with Chief Executive colleagues. We've had feedback from an Iron Bevan Health Board with some useful recommendations on how we might look to refine this. That's not to say that the documents aren't approvable. It's just some useful best practice following an internal audit they've had. And I think the commitment we've made is that we've asked for this process to be reviewed by internal audit in Q3 to make sure it's appropriate for the organisation, and that feedback from colleagues in Iron Bevan will feed into that process as well to make sure when we do respond or we have any actions, it's in one place. We'll have to improve from there as part of our first anniversary review of this process. But positive feedback so far, as you say, except this will be iterative in nature, but it's the first step in the right direction to getting this moving forward, how we scrutinise our risks and take assurance moving forward. But we're looking for endorsement of each of those processes, procedures and the documents that accompany it.
Thanks, Aaron. Comments, questions, observations? Stacey?
I was just going to add, thank you to Aaron for all of the work that he's done. It's been a significant piece of work and I think it's progressed massively over the 8 months, Aaron, that you've been looking at it, so thank you for that. The only thing I'd add is that it is underpinned by a really robust process internally as well, and I think some of the illustrations in terms of how we manage those risks at different levels is really helpful. So just to say thank you and a huge support for the team internally.
And the risk management procedure is aligned to CTMs, which is obviously really important as we're a hosting body. So it's not a blank sheet of paper. It's been utilised in the risk management approach that Cwmtâp Morgannwg undertake. Any other comments?
Just to say, I think it's kind of helpful, and I recognise the work that's gone into it. Risk management frameworks and stuff like that isn't always the thing that pops to the top of the popularity agenda, but it's really important. And welcome the chance to have a couple of stabs at it as well. It's been through a good old process, and I think we all recognise also that risk appetite and the risk register will be an evolving, and it will be an iterative process.
And we've got to start somewhere, haven't we? In terms of making sure that we're utilising this different way of working, different approach, and which will then be adapted and changed and modified and becomes more sophisticated over time. So I think that my recommendation is we endorse this. Let's use this now as a live approach to our approach to risk and take decisions based upon it as we are checking this out over the course of the next couple of months. Anything else? We endorse this as approach. It sounds, Aaron, that's a bit of a damp squib, but I know that a huge amount of work's gone into this. So thank you very much for that. And it's great that we've now got something that we've been concerned about our approach to risk for ever since JCC commenced, when it was the slotting together of two approaches to risk, and to now have one which has had careful thought and consideration. That's really positive. Great, thank you very much. Final item on the agenda is in relation to Manchester Air Arena Inquiry Report update. Claire, and again, we've read the report and we've also had conversations outside of public committee meetings with the joint committee as well, which sets out the context for this. So anything you wish to just highlight to us, Claire?
Thanks, Claire. No, in essence, the report provides the outline of due diligence that's been applied to the receipt of the report from WAST, and recommends that we accept the recommendations within the paper, and specifically that we now conclude by writing formally to WAST on the outcome of that review, and also to Welsh Government advising them of our approach. But as you said, it's been read, it's had further detail, conversation elsewhere, so nothing specific beyond that, Chair.
Thank you. And the members of the joint committee have separately received the independent review from the expert, and so obviously are aware of the findings of that report. Rachel, I'll bring you in a moment. Just see if there's any comments or questions from any members of the committee first. No, Rachel?
Yeah, just to say a big thank you for getting to this stage now. I think we've been working together on this for a while, and certainly that the conclusion of your scrutiny and consideration and a response back to us would be really welcome. A couple of points I just wanted to us again kind of confirm that there are ongoing risks in terms of some of those recommendations that we've made that are largely supported by your scrutiny, but at the moment we don't have the funds to take forward. So again, I think we'll be looking to bring those forward in whatever forum or process you would want to see them as part of IMTP planning. And just one other point to note: you've got in there a note that you supported our plan this year to put some resource into a small area of risk, and if just to note that obviously I think we all know that was done through savings elsewhere within the organisation. So it was a kind of a risk-based approach, trying to support the Matt Arena inquiry recommendations, but risks elsewhere in the organisation as a result of savings that we've then had to make. So it was just to note that as well. Thank you.
Thanks, Rachel. Just in terms of where we are in comparison to other commissioners, I think in the UK, I'm not aware of any other ambulance provider that's had the level of response that we've provided. If you're aware of anything else, Rachel.
No, I think my understanding from Emma is that I think they are now collectively, the ambulance services in England are trying to kind of get a more of a collective approach back to their government to say, we need something a little bit more collectively and stronger. So I think I agree that it's been a really thorough review here, and as I say, really welcome. Thank you.
Yeah, just thank you to Rachel as well. I think there is a level of assurance that we can take from the provider, use his internal processes to prioritise, the risks that they face as the provider as well in the context of the resources that we have available. And I think I make a very good point, and I think it's probably worth us making sure that our more detailed groups now through our commission structures are just kept cited on it. But I think, useful assurance from provider really on the prioritisation of risk.
So we've been asked to note the report and approve the proposed way forward. Do you agree with that?
Yeah.
Okay, thank you very much. Forward plan of business, Aaron, anything?
It's shaping up to Chair.
Okay, do we note the forward action business? Great. Any other business? I understand there's a QSOC development day that's taking place on the 7th of September. And if any other joint committee members would like to attend, then they're very welcome to attend. And if perhaps they can let people know. So then I believe this is going to be your last formal meeting I know there's a development day in August, but this will be the last formal committee meeting.
I believe so, Chair.
And so can I, on behalf of the committee, thank you for your support as a member of the committee. Always supportive, always challenging, always insightful, always here. Which is all very positive. So thank you very much, and all the very best for your new role in Hampshire.
Thank you all very much. It's been a real pleasure to work alongside you all.
Paul.
Yeah, Chair, just one quick AOB from me. I've been asked, I'm the Chief Exec Lead on the Diabetes Network, and the Diabetes Network have asked me, and I think Yolo's been a party to some conversations on this as well, about a request for consideration around a new drug that's been brought forward for early identification of type 1 diabetes, which is teplizumab. The consensus was that if it was something that the network wanted to do, that it would be worth a chief exec bringing forward something into this group for potentially consideration. My suggestion would be that we look at this through the CCLG in the first instance and see if it's something that we might want to consider for consideration to next year's plan. But I committed to bring it to the group as an ask. But Yolo and I has been involved in some conversations already on this topic. I know we're only talking about 20 patients a year potentially, but I think for me it's something that needs to be. We need to find a route through, and I'd suggest CCLG in the first instance.
Yolo, is that would be your view?
It's tricky because we don't commission type 1 diabetes for either children or adults. So we would then be saying, just because it's a drug, we should be commissioning it. And I don't object to that, and I don't think that's inappropriate at all. It's worth saying that the normal pattern would be the prioritization process that we've always operated. So we would take it to prioritization, and the prioritization panel would determine whether we should commission it or not. So I'd welcome the opportunity to take that forward. But if we were discussing what JC wanted to prioritize, I would use the example, do you want Sabre for prostate cancer or this drug? But I think if Paul's raised the question, we have to address it for sure.
So it's come forward. Let it go through our normal process, I think, is the should be the view.
Yeah, no, and just to be clear, I'm not
up.
advocating. I'm not advocating either way about the funding. I'm just channeling it through. And there's a paper being written, so I'll send that through. And maybe if I send it through to Yolo, then it can come into and I'll send it through to CCLG as well.
Yeah. Thank you.
Yes. Thank you. No.
I suppose I would just reflect as well, it raises some of the questions around our operating model, doesn't it, about what happens to things that don't fit in our existing portfolios, because it wouldn't be a special, here's diabetes, it's not specialised. So exactly. So, you know, how do we manage some of those things, and how do we mitigate the risks?
And the outcome maybe is it's not our responsibility. Yeah. But then whose responsibility might it be? Goes back to the heart of the nub of the question we've been discussing. Any other business, Rob?
Yeah, just picking up that point, and I'm not familiar with the drug, but I'm not sure why it needs to be considered by JCC. The responsibility of every responsibility lands with the health board in one way or another. Not sure where this is with AWMSG. Sorry, Paul, I'm not familiar with it, so I don't know. But there perhaps needs to be a different route to consider rather than jumping straight to JCC. But appreciate this one route. But if it's not in the portfolio, then it's back to health boards, isn't it? I don't think that's a difficult one, to be honest.
Rob, that's helpful. Let's, Paul, you've raised this with us. Let's have conversations outside of the meeting in terms of the best approach of dealing with the issue you flagged.
Yeah, exactly. And if it's deemed not to be appropriate, then we'll need to go through it. It's one of those ones which there's a danger it falls between cracks, and also then we end up with a postcode lottery of some people saying, yeah, we'll fund it, and others saying we won't. So, but we can pick that up outside. That's fine here.
Any other items of business? Review of the meeting. Any issues I wish to flag?
Timekeeping.
That's slightly over the 1 o'clock I did suggest. But only just.
Just.
Anything?
No.
Okay, great. Thank you very much, everybody. And see everybody at the next meeting, 22nd of September, and then we've also got a meeting, a development session in August. Thank you very much.
Thank you.
Fine.